Oh, I better get ready.
Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why.
Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. And tonight you're stuck with just having us. No guests. We are the special guest for this evening. Of course, I cannot do this alone. Joining me is my co host, Dr. Rogers Kane. How are you doing this evening, Dr. Kane?
I'm doing great. You couldn't say your favorite position because you look at your other position may be listening, so never say that.
I can say one of, huh?
Yeah, you can do one of them. Just don't say duh.
I know, right? Also, from behind the scenes is our technology guru, expert, wizard. We call him all sorts of things. You can also call Tyrone Jackson. How you doing this evening, Tyrone?
I'm doing well, Miss Jocelyn. How are you doing?
Oh, I'm doing just peachy. I'm a day after my birthday. I had a marvelous weekend celebrating
Awesome.
my birthday. So I am doing amazing. January is a good month for me. I'm blessed to reach another birthday.
Yes, yes.
Yes, yes, yes. So today we're launching a special mini series called From the Exam Room to the Living Room. This is about more than health facts and medical advice, it's about trust. Because even when the science is sound, the outcomes don't always follow. And often the missing link isn't information, it's trust. In communities across this country, especially communities of color, people are navigating fear, lived experiences, history, and real life barriers that don't fit neatly into a 15-minute appointment. In part one, we're starting where it all begins, the trust gap in healthcare, why it exists, how it shows up, and why closing it may be the most powerful health intervention we have. Dr. Kane, I want to just really start this conversation by asking you, from a physician's perspective, how do you recognize when trust is missing, even if a patient doesn't say it outright?
Well, let me say this preliminarily. One of the, first of all, I want to thank our audience for joining us this evening. We appreciate everybody that join us every week that they
Absolutely.
join us. We also understand that sometimes people can't get to us every week, but they do get to us when they can, and they may go back and look at us on our website because I've heard from not too many, a lot of patients and friends and families that the information that we bring is great information. And while they may disagree with some of the people that be on our show, they most certainly acknowledge their truthfulness and when they, in terms of how they present um, their opinions and concerns as a physician for the past, I don't know, umpteen hundred years, been studying disease and prescribing medications, and also as a pharmacist, being one of those guys that previously becoming a physician, interpreting what those physicians were doing. One of the most important lessons I learned was that, didn't come from a textbook. It came from listening to my patients. Okay, and as a pharmacist, also listening to uh, who would have been my clients, a clientele, while I worked at the pharmacy. I've seen throughout my years, while I worked in the hospital, while I've worked retail and pharmacy, while I've worked as a community physician, which has been the bulk of my time, but especially doing my training, which is what helped me become the kind of physician that I am, not just because of the academia, but because of the exposure I had to people and people trusting me when, be quite frank with you, it was like learning to ride a bicycle. I just had started to learn and I didn't know everything. I might even be able to say I didn't know anything. But over the years, I learned quite a bit through academia and through my patients. And I can see how the trust or lack thereof can determine, how someone follow through on their healthcare advice, um, the seeking help early or avoiding the healthcare system altogether. Any and all of those things I've seen as a physician. And when the outcomes fall short of what we want it to be, and many times our expectations, the focus, the conversation starts to focus on patient behavior instead of the system of responsibility. So, I hear many times, particularly new physicians or young folks in training, and a lot of times uh, while I'm in the exam room talking to patients, they're they have the level of skepticism as to do they really need to seek uh, help from our healthcare system. It's really bad these days because I think a lot of physicians, a lot of nurses, and a lot of the other healthcare personnel, and those people involved in healthcare, they're being undermined with what they're trying to do for that patient or a group of patients or whatever it may be. And so even though they're working their hardest to do the right thing for the patients, people just don't trust them. It kind of reminds me of teachers, when these teachers, they work so hard and they get so little, but yet their heart is into that child, in their classroom, and get, instead of getting thank yous from like in my day growing up, instead of getting you thank you from the parents, they're getting chastised and beat up, not necessarily physically, even though sometimes it does. They're getting chastised and beat up on how they're trying to conduct their classroom and trying to help that student. Not like with anything, not everyone is out for your best interest, but the overwhelming majority of people who really want to do what they do will put their heart and soul into it. And I see that in teachers, I see it in nurses, I see it in physicians, I see it in other paraprofessionals and healthcare personnel. So what I'm trying to say is, from the exam room to the living room, we should be, and as well as, especially when it comes down to um, uh, some of my colleagues that I know, many of my colleagues that I come in contact with, we try to create space for dialogue. And while I'm not saying that only a cultural identifiable identity, I'm not only saying that a person who looks like me or identifies with me is the only one that understands, but at least one who understands my culture, our culture, of the culture in which they are treating their clientele, whether it's in Little Havana in Miami or over on Jacksonville North Side. They're trying to actually create some honest dialogue about what really shapes the outcome beyond beyond the clinical setting. So today we're starting this trust, and I went a long way around to say today we're starting to trust, starting with the trust gap in healthcare, because before we can talk about prevention and compliance, and prescriptions or lifestyle changes, we have to talk about trust. Because if the person does not trust what you tell them, more than likely they're not going to do or follow the advice that you give them. So even with the best medicine, if you don't have trust in the people that are offering it to you, you may not do it. You may not, perform what they ask you to do in terms of testing and so on and so on. So, because the best medicine, even the best medicine, can fall short of achieving the goal it wants to when there's no trust involved.
Yeah, I know when over the years, we've done, and Tyrone, I want you to unmute because I want to direct this question to you. But over the years, as we've done work, Dr. Kane and I, Tyrone, with men's health, they're the toughest crowd that I've dealt with in terms of follow up on their health care. Tyrone, I want to ask you, do you think when we talk about trust, do you think that people or have you heard people say that I don't trust going to the doctor because I don't want to be anybody's experiment? I remember the Tuskegee incident. You ever
No,
heard?
I've never heard anyone of my friends
Okay.
ever bring that up. But here's one of the challenges that drives a untrust in the men in my age group that are targeted. Far too often, medicine and medical treatment precedes pain. We've been taught by society that it's supposed to hurt, and if it doesn't hurt, then nothing's wrong.
Mm-hmm.
But the facts are overwhelming that oftentimes things don't hurt until they're at the point where they can actually kill you. So when we're talking about bridging this here trust, we have to find a way to have conversations that say to men that it is important to be proactive. It's important to know your numbers. You've heard us say that 1,000 times, but it's important to be engaged with your health because pain and hurt is not always the first sign that you are sick.
And you're right, Tyrone, because then people talk about high blood pressure being a silent killer, which it is. Okay. All the damage that's being done by that blood pressure over the years as it remains high. And, and I can get into the dynamics of it, but that's not what we're trying to do in this conversation. That the damage that's being done, the damage from diabetes that's being done, if it does not cause pain, why do I need to treat it? Why do I need to listen to what you're telling me? Now, I will say, and this is going to sound a bit prejudicial, but I do speak my mind along this line. Black men are the worst offenders when it comes to my clientele, and I think many clientele, because we tend not to go seek healthcare advice or treatment in our young age. We have that sense of omnipotence, and so we don't really, like what you say, Tyrone, it ain't hurting, so if it ain't broke, don't fix it. Along that line. Black, women, I'm just going to say women in general, but especially Black women, they will go and take care of themselves. They will impose their desire to make sure that things are going well on their children. So they'll make sure that they get taken care of and so on and so on. Black men, while they may love their children and stuff, they're not as adamant about taking them to see physicians as Black women. And again, I don't want anybody to say that we're speaking in the terms of unilateral. No, that's not the word.
Absolutes, no absolutes.
Absolutism, right. We're not speaking in terms of absolutism. We're speaking in terms of what we've encountered. And Ms. Turner, I know, your years over in the health department is a healthcare. I'm gonna call you a coach for sure, because you've coached many people regarding their healthcare. I know in many years you've seen just that. We've had conversations, even when you were working over at the health department, and we've worked together on men's health for many years. It's mainly through your heart, your efforts, all the effort that you put forth to try to bring that to the men in Jacksonville. Did a lot of work, a lot of hard work to do that. People don't know what what you did to be able to just to pull those couple of days off in terms of where we're providing certain kinds of health care to men in general that may not have had any. But even that gets to be frustrating sometimes because it's so much we try to give them and then it remains on the table. It's like growing fruits and vegetables and then they die on the farm, not even picked.
Yeah, I think that, we've been talking a lot, and the work that I do during the day now is related to trauma. And I was talking to a group of ladies the other day, and we were talking about how a lot of the experiences that we had, those adverse childhood experiences, they are it's trauma. And we don't recognize that it's trauma. We don't recognize that sometimes people, when it comes down to trust of the healthcare system, talking about from the exam room to the living room, sometimes it has nothing to do with you, Dr. Kane, telling them, prescribing the medicine, having a conversation about here's what you need to do. Sometimes they are just really thinking about, well, I know I had a conversation with a gentleman once, said he was never going to stop smoking because his father lived to be, 90 years old, and he smoked all of his life, right? So sometimes it's about the experiences, folks' lived experiences. If it worked for their grandma or granddaddy, then it will work for them. And they don't see the need to go. And we saw during COVID, that's why we started this podcast. We saw during COVID how people who had been going to medical providers for years, all of a sudden they weren't trusting them anymore. They were listening to Dr. Google or some other sources, politicians who had no medical background, talking about, the vaccine and the virus and what you should do. And so when we talk about the reasons that people don't trust the healthcare system is sometimes, Dr. Kane, I hate to say it, and it's not all physicians. Sometimes it's because they are not listened to. They don't believe them. The doctor come in with a preconceived notion about this person, or, oh, here comes Jocelyn. She never listens to what I say. Let me just go ahead and put these 15 minutes in with her and whatever, instead of really taking Jocelyn where she is today, because you don't know, you may know, I may have shared with you a little bit about my background, but you don't know what my lived experiences are that brought me to that point. We've talked in the past about domestic violence, domestic abuse. You don't know sometimes if the patient is not sharing some things that are going on in their house. And then when the physicians prescribed medications and tell people you need to get the medicine, and then we've seen in the news people are going to these drugstores and standing in line for hours waiting on their medication, or waiting for days to get their medication filled. So there are a lot of things, and you think about those things that are compounding, and then you're talking about how to pay your electricity bill. So things are compounding. It's not always about the obvious to you, but it's about other things that are happening with people. And you're right. Again, pain not taken seriously. People are feeling rushed to talk to Dr. Kane. You and I have talked about it over and over again. When people will come in with a long list of questions to you, but you have to follow the guidelines of the insurance and talk about how long you are supposed to spend with patients. So that's why I like when we have these community dialogues and community discussions, because it's that at that point that you can share, and other physicians can share with their patients outside of the exam room. Here's what's really happening with the healthcare system in America. If you're just tuning in, we launched tonight a special mini series called From the Exam Room to the Living Room. Tonight, we're talking about the trust gap in healthcare, why it exists, how it shows up, and why closing it may be the most powerful health intervention we have. Not necessarily the get out and walk every day. Yeah, I can get out and walk every day, but if Dr. Kane and other healthcare professionals cannot build the trust with their patients, then that's it's not going to happen. I was sharing with Dr. Kane, I was looking for a physician for a relative, And I looked him up, and on a particular health insurance health plan, they have somebody who made a comment about Dr. Kane. What was it, Dr. Kane, over 10, 12 years ago?
Yeah. Well, actually, it was in 2012, 2013.
Yeah. And so you think about it, and then just in comparison, there's a restaurant complaint about one of my favorite restaurants that's been out there since last summer. I'm sure they've cleaned it up. So sometimes I want, and I say all this to say, I really want people to do their homework and not just believe what they read online. Go the extra step, have some conversations with people. And I also want other people to be aware of past medical abuse and exploitation. I want to ask you another question, Dr.
Wait a
Kane.
minute. It looks like Tyrone wanted to say something, Ms. Turner, before you.
Oh, go ahead, Tyrone.
Only thing I wanted to say is I want to follow up on what you're saying, Ms. Johnson, because it's really important for people to know. And I think we miss some of the most obvious. If you've ever heard a conversation between two women, the depth and detail of the conversation can be very broad. It can be very deep. Whereas men can take 2 to 15 seconds. How you doing? How the family doing? And they feel like they've covered everything.
I feel
Do
you,
they
bro.
wait for the answer?
That's pretty
But
much
do they
it.
wait for the answer? And do they really get a real answer, though, Tyrone?
But here's the thing, though, that I was trying to get to is that how important it is for men to be engaging in conversation with their friends and telling them and having conversations with them about their medical experience. It is so interesting to me when I went through prostate cancer and I talked to my friends, the number that mentioned, they didn't even know what their PSA number was.
Myth.
Then I explained it to them. And then so the relationship with me then urged them to go to their physician and ask questions. And I brought this up because one of you has said about the number of questions that you have when you go in to see your physician. That is so important. You should have a list of questions. Far too many times, there is no list. I'm going to go in here. I'm going to get done with this as quickly as possible. I'm not asking him anything. Whatever he tells me, it is what it is because it don't hurt. And in doing that, I was able to assist a couple of my friends to have their numbers relooked at because their numbers were beyond where they should be.
Yeah. The one thing I will say, Ms. Turner, the biggest complaint I ever get from any patient, and you know, I let other people make the decision. The biggest complaint I ever get is that, you know, I go in there and Dr. Kane is a little slow. It takes him too much. I spend too much time in the office. I spend an hour there, waiting. And it's, most of the time they in and out within an hour, but I spend too much time there. But I get in the room and they got a bunch of questions like what Tyrone mentioned. Sometimes they're written down, and even though they be upset with me because I was a little slow getting to them, I answer each and every question. Sometimes my staff said, Dr. Kane, they can't expect you to address all their problems, each and every last one of their problems, and we stay on board or stay on schedule. I said, yeah, but this guy, it took me too long to get him in here. Okay. And so it ain't so much I know they be thinking they're trying to take advantage of me, but I'm actually trying to take advantage of that opportunity to try to get to him or her. And most of the time it's a him. But I'm trying to take advantage of the opportunity to get to them and discuss with them the whole status of their health. I may not resolve that issue, but I want to make sure I address each and every question they have, as long as they do it reasonably, and keeping, trying to make sure they respect that other people that respect my time, not so much that I'm trying to be in a hurry to get them out the door, but that I do have other people that have other concerns. Nobody any more important than the other person, but you have to earn that trust. And the only way you usually earn it is to address their concern. If that was intentional, by the way. If you're not listening to those guys, that's what they hear coming from you. Blah 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 blah. They zone out like a deer in headlights because they don't think you're concerned about their health.
Yeah, and that's so true. But again, I really want to get back to how does time pressure in clinical settings affect trust building though with patients? Because again, you go ahead.
No, you go ahead. Finish it up.
No, go ahead. Go ahead.
Okay. Well, here's the thing. You have a lot of patients saying he was in there. I think one of the things that you were talking about before, he was in there 5 minutes and he gone, and or he was in there 10 minutes and he's gone. It really depends on the situation. When I first see a patient, I want to know whatever is everything that's going on with them. If they've done the questionnaire, I can narrow down on things that express a whole lot of concern with me. But that may not coincide with what their concerns are. So I want to listen to their concerns just as well. Okay. And as I view it right here, and I was just about to say it, I'm glad Mr. Spruill mentioned that. A lot of times they don't want to hear or don't adhere to what we say because they're afraid of what the results may be or the outcome may be. That has nothing to do if I'm checking your PSA for your prostate, since we've mentioned that already. If I'm checking your PSA for your prostate and it's high, what that does tell me is that we need to investigate why you have such a high PSH. But they may not want to investigate it because I've heard too many times, it might say something I don't want to hear. Like it might say I got prostate cancer. So sticking your head in the sand going to make it better. Okay. I will be pretty frank, as both of you guys know, I will be pretty frank with the patient in terms of that question. Not rude or crude, but I'm not going to try to layer it with a coat of just being kind and nice and sweet, and it's not doing that individual any good in terms of the outcome of whatever it is that we're trying to look at, the outcome of their health. I got to be upfront. I got to tell them the truth. And that's one of the things, the first thing I tell them. It may not be the first thing, but before that first visit is over, it's like, now, I don't know who told you about me or how you got here, but one thing is, I don't lie to my patients. Okay? I'm going to tell you the truth. You may or may not like the outcome, but I'm going to tell you the truth, and we're going to wind up discussing how we can help remedy whatever the problem may be. But we got to work together on this. You're the pilot and I'm the co-pilot. But if you want me to be the pilot and you be the co-pilot, I don't have a problem with that. But we have to work together.
Yeah, a lot of people don't always understand medical jargon. I know we've had different physicians on the show, and I know you've come behind some of them and said, let me explain what that was. So we really need to make sure, and we've talked about health literacy. We really need to make sure, and that's what I hear on my end as a health educator when I'm doing community engagement, is people saying, well, when I go to some doctors, they talk over my head. I don't understand what they said. I left with some medicine or prescription and they told me I need to eat better, but that's all they told me. We've had Linda Brown on, our registered dietitian, because I believe everybody should have a team of healthcare professionals, your primary care physician, a registered dietitian. I always say know a good nurse, a social worker, right, and a pharmacist, even, to have a conversation, or just tune in to Pause for the Truth and listen to the plethora of healthcare professionals that we have, because there's just far too much mistrust out there. But for our physicians who are listening, I would like to say that, from what I hear from people is that you don't always explain the diagnosis good enough that is understood, that the person said, well, they told me I have such and such, but I don't know what that means. Or either they'll bring the paperwork home that they were given and give it to a loved one, and the loved one will say, what is that? And I think that's a shame that people leave a doctor's office not fully understanding. But I also want to put the onus back on the individual. If you don't understand what you were just told, ask a question, right?
Well,
And if
now
you,
there's
the
another
doctor
good part
let
of
me
that.
let
Go
me
ahead.
let me just say this, Tyrone, real quick. And if the doctor explained it to you and you don't understand, it's a good nurse in that office who will help you, who will break it down for you. Go ahead, Tyrone.
The other thing is there needs to be a relationship between the doctor and the male patient prior to coming into the exam room, because there's a value in that. When I trust a man, then my ability to ask him questions, regardless of how well I can discern what he's saying, is greater because I don't mind asking a follow-up question. And then if I'm asking a question and he doesn't give me this irritated, as if, don't you understand what that is? But when he says things like, okay, well then let me break this down to you. Tell me if you get it. You know what I'm saying? Those are the kinds of things that make it easier for the conversation to continue on, to get clarity on the medical jargon. Now, I can only speak for my doctor, my primary care doctor, and the relationship that he and I have. And it starts before I come in the exam room.
Now, the only thing I would help to clarify with that, Tyrone, is if you never met the guy, a lady, we never met with them as a primary care, never seen them before. The trust is established when you sit down, you have the conversation, you make sure that that person understands, and I'm talking as a physician now, they understand. I try to get them to understand what kind of person I am, what kind of practice I have, that I am concerned about their health when they're in that 10 by 10 room, that they're the, it's like being in Las Vegas. What happens in Vegas stays in Vegas unless you tell me or allow me to share it with your loved ones. And so they have to have the trust that they won't hear about what's going on with them in the street, or, from the spouse, that they may not want to know what's going on for whatever reason. And that is true. That's not going to happen unless that individual allows me to do so. I will say this, and I know we got to do our mid-show moment, but I will say this. When that person do get in there, it's on the honest is on me to earn their trust. It's up to me to discuss with them and do the best that I can with that relationship for that amount of time. Sometimes it takes several, and it ain't just men, but sometimes it takes several meetings. I've had the 95-year-old come in and look at me up and down like, who is this young whippersnapper? And they got to be 95 to call me a young whippersnapper. That's not that 50-year-old, but that 95-year-old. Who's this young whippersnapper trying to tell me so and so and so? Dr. LeRae or Dr. So and so was the best doctor who's been dead maybe 50 years or something like that. But he was the best doctor I ever had, yada, yada, yada. So it's my job to sit back, and that's how you got to look at it. My job is to take care of that patient. And I'm not the only one to feel that way. So don't think I'm putting myself up on a pedestal like I'm all that. Because many of my colleagues will do like that. And especially those who are culturally familiar with the individual that they serve. But my job is to to earn that trust. And I realized that it may not be the first visit. And the reason I said that, and lady come in today, I remember the first 3, 4 times to come in, she would never say a word. The daughter start wondering whether, the daughter start mentioning stuff about whether or not it's dementia, whether or not it's this, whether or not it's that. And the patient just sit back and listen to him. But I didn't just speak to the daughter who brought her in with the complaint. I would hush that daughter up, okay? And now I want to talk with that person because they're the ones that can tell me how they feel. The daughter can't tell me how she feels, okay? She can tell me how she feels if she has enough ability to be able to speak, no stroke or nothing like that. But the more you can sit down and talk with them, sometimes just sit right there and get in the face. When the daughters or whomever, if it's a son or daughter, when they start talking, it's like, no, let her answer. I can get what you got to say later. But the patient needs to be able to talk to me.
Yeah, I had a nurse tell me the other day, and she's an older nurse, that she's finding with age that doctors are talking to her different, as though she doesn't understand what they're saying. And I tell them, did you tell them you're an APRN? Do they know? And she said, oh yeah, they know. But still they talk to her as because of her age, rather than because of looking at her as the individual. We're going to take a moment now.
APRN means advanced nurse practitioner. So they're a doctor of nursing. I just want to make sure the people that are listening know that.
Thank you, Dr. King. I'd always break it down for us. So as you know, each podcast, we like to feature what we call a mid-show minute based on tonight's discussion. So we never know what Tyrone's going to bring to us. So take it away, Tyrone, and we'll be right back.
This is Pause for the Truth, your mid-show minute. I'm stepping in to name what too often goes unnamed, the trust gap in healthcare. Today isn't about blaming patients or praising tech. It's about closing the distance between a doctor's stethoscope and a patient's heart. Here's the headline. Trust is measurable, and it's unequal. Only 39% of Black Americans report high trust in the healthcare system, compared to over 50% of white Americans. Insurance? Black Americans remain uninsured at about 9.7% versus 6.5% for white counterparts. And the cost hits harder. On average, Black households spend 20% of annual income on premiums and out-of-pocket costs, nearly double the 11% national average. But the gap isn't just numbers, it's history meeting the present. From the Tuskegee syphilis study to the unauthorized use of Henrietta Lacks's cells, Black bodies were treated as data points, not people. And myths linger. Studies still find trainees believing Black patients have thicker skin or feel less pain, leading to undertreatment when care matters most. Add weathering, the biological wear and tear from chronic stress and systemic racism. When you walk into an exam room already carrying that load and your symptoms are dismissed, trust doesn't just slip, it snaps. Representation matters too. Black people are 13 to 14% of the U.S., but only about 5% of physicians are Black. If you've ever had to translate your life to someone who doesn't speak your cultural language, you know why trust feels rationed. And now the frontier is digital. AI tools decide who gets extra care, but many are trained on biased data. If trust is low, minority patients are twice as likely to reject AI-driven diagnoses. The fear is real. Will the machine just automate yesterday's bias at scale? So, what does it take to move from flying to soaring? Radical transparency. Hospitals must show equity data, not just success rates. Cultural humility, beyond competence, to listening like the patient is the expert of their own body. And community integration, bringing care back into the living room, with community health workers and trusted local voices leading the bridge. Because this isn't abstract. It's the mom comparing bills at her kitchen table. The elder deciding if today is worth another waiting room. The kid who wonders if anyone will believe their pain. This is Pause for the Truth.
Wow, Tyrone, that was wonderful. Absolutely wonderful, because I was going to get into financial reasons why people don't go to the doctor. I've had a few people tell me because of I call it a medical crisis in America, that they cannot afford health insurance. Their insurance went from $300 or $400 a month to 3 times that amount.
Mm.
And
So
even
people
more, especially right now, it's about to go a lot more than 3 or 4 times that amount.
yeah, so people are having to make a decision. And a lot of people, it's even been on the news where several people said they just dropped their insurance. They're just going to have to wait until they end up in the ER. So people don't realize that people are suffering. They're having to make that tough decision, and they might have diabetes, they might have high blood pressure, and they're taking a gamble, hoping that everything will be okay, praying that everything will be okay. But sadly, if they are not getting the care they need, then they're going to end up in the emergency room. Now, of course, we have volunteers in medicine, the federally qualified health center with Agape Health, but still the safety net providers, they are not going to be able to provide everything. Jack's Care Connect here in Jacksonville or Northeast Florida, where you can call and sometimes talk to a medical professional to divert you from having to go to the emergency room. But it's real now, and we need to have the discussion. And Dr. King has said it to me. When are we going to start the series on what's going to happen to those folks now who don't have health insurance, but they are going to start getting sick? And what do we do now? Again, compound that with the trust that people already don't have in the healthcare system, or the trust that people are not feeling that they get from their provider, because many people don't feel that I am an African American woman. The level of care I need might be different from a woman of another race or culture whom we may be the same age. That we do need to consider race and culture when we are having a conversation or we are considering treatment for folks. Dr. K, you look like you want to say something.
Well, if you recall in previous shows, on a previous show, I mentioned epigenetics and what that, just a recount, uh, as simple as I can make it. It's about it may not be an automatic gene transfer from your past family history as it relates to geneticism, as much as it is about the effects that the environment in which you are exposed to and in which you are participating in has on your health outcome. A perfect example would be Black women with the way slavery and the things that happened to over the past 400 years has affected Black women in terms of how blood pressure and stuff of that nature has had on them. While we may not be able to go back to 100 years ago and actually show the gene that caused that blood pressure to be that way, but the impact of the life that has been imposed upon them, okay, in terms of behavior and experiments and environments, as you most certainly can show our audience, that it can help somewhat change the DNA hardware. Okay. Now, the other thing that I tend to see a lot is that we have a lot of people who really want good health care. They're working 2 jobs, but those jobs may be to pay rent and to put food on the table and don't have the ability to get insured. But then you also have a lot of physicians when they work for certain companies. And I'm not calling anybody, I'm not going to call any companies out, but if they work for these if they're employed physicians, as much heartfelt sympathy and empathy that they have, they're very limited by those their employers as to what they can do for these patients. You know, you got your 10 minutes, get them in, get them out, you know, let's do the billing and so on and so on. But the patient may have a whole lot of concerns, and or if they can't afford to even see a physician, now what do they do next? And so you've had a move where they're trying to employ all the physicians. There have been some out there that have been resistant to being employed, and you're probably looking at one of them right now. We don't make as much money. We, you know, a lot poorer than our white counterparts. Um, and but they really love the idea of taking care of people. One of the things I want and again, it's not about me and this, but one of the things that I do make sure I adhere to, and that is the rule of thumb. Like, okay, what if this was my mama? What if this was my sister? What if this was my brother? What would I want a physician or
Mhm.
person capable of performing these tasks that I can? What would I want them to do for them? And so if I say that, that means I got to be ready to do it for my patients. And there are many physicians out there like that. Unfortunately, medical school has not, or medical education has not been as heart giving to those individuals who want to be doctors. They're just, you know, they can't afford to go to medical school these days. They come out and go to medical school and then come out. You know, you're looking at hundreds of thousands of dollars of being in debt. And so these people, you know, these doctors come out, might went in with all good intentions, but they come out, they have no other choice but to go and work for someone else who may be investors or whomever. And they're all about that dollar. And that physician can be a very, very, very stressed in terms of this is what I want to do, because I've been that way. This is what I want to do, but this organization is limited in our ability to be able to do it. And you know, it's like I don't, yeah, I'm gonna be burned out real quick. You know, I don't think I can do it this way, because I don't want anybody just to go in there and pat my mom on the back. You a maid? That's my mom. She might not like me telling that. But anyway, you a
Yeah, there
maid?
was a comment, Dr. Kane, there was a comment about what someone made that, you know, when you talk about trust, so if you have multiple physicians and one doctor will prescribe something, but then you go to another doctor and say, no, stop taking that because it causes cancer. Now, what is a person supposed to do in that case? You know what I mean?
Right,
Generally, we'll go to Dr. Google and see what he says, or now Chat GPT, and see what
right,
Chat says. But I think, and you know, what I would do is go back to the prescribing physician and say, what are the risks, or go to the pharmacy and ask the pharmacist, what are the risks of me taking this medication? And we didn't even talk about that, Dr. Kane, in terms of being prescribed one medicine, and then you go to the pharmacist, and the pharmacy, thank goodness, will tell you, make sure such and such and such you eat. Well, and the prescriber may have said it, but
right,
I like how some pharmacists will follow up and say, make sure you don't eat, you don't take this medicine, you take it rather before you eat, and yada yada yada. So I think the reinforcement comes. But what happens, Dr. Kane, for someone who is prescribed medicine and another physician will tell that person don't take that medicine? How would you handle that if
All
that
right.
was your
So
patient?
if someone comes in, and that depends, I'm just going to look at two different scenarios. If one says, look, my nephrologist say do this, but my cardiologist says do that, and they're bumping
Mhm.
heads in terms of what they're asking me to do, you know, I will ask them, did that nephrologist, the kidney doctor, did that nephrologist explain to you when, why, and what happens when you take this meds? Did they explain their positioning on that? Because you don't just say don't do this and then don't explain to it. And even
Yeah.
with your kids, why don't you go over there and bother that electrical outlet? You know, and in my day, you went over, you know, sometimes the dad said, no, 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 hold on, let me go there and stick that fork in, and let's see what happens. It's a
Yeah,
trial
what a
by error.
person said, they said it would cause, the medicine may cause cancer.
Right, right. They say it might cause cancer. So But then I go to the other guy and they say, nah, that's not true. Or they say, well, yeah, there's a potential for it, but to what degree? So you want to ask each person, why did they say that? And what's the data behind it? And not in that scientific term to where you can't understand, but to at least give you an explanation of why it is that this may cause that cancer and why you say that. Then when you go see the other person and or discuss with the other person the contradictory explanation of that, and you ask them, well, why do they say that? I'm not necessarily, some of my patients will say, well, the other doctor told me so and so and so. I say, who's the other doctor? And they say, well, I'm not, sometimes they don't want to really rat out the other physician. I'm going like, look, you're not ratting them out. You know, I don't have that kind of ego. This is not about me or them. It's about you. So let's see if we can clear up what it is. And if that person is correct, and I see they're correct, but I was wrong, I'm quick to say, well, I'm wrong. You know, they know more about this than I do, but let's investigate it. I will look into it and see if there's anything else that may be, I may need to educate myself on it. It might have been the absolute truth 3 years ago. But then, ongoing research has revealed that's not the truth. And so, but I didn't keep up with it. And so then I have to go back and validate my answer to myself first, and then try to validate it to my patient if I believe in what I said.
I want to talk about, before we close the show out, Dr. Kane, the consequences of mistrust. What's the cost of, or no, let me rephrase that. Have you seen patients delay care until a condition becomes life-threatening, and why?
Yeah,
Like how Ramon brought that up earlier.
Multiple reasons. Sometimes the physician misunderstood what the question that patient was asking, or the concern that patient had asked. And a lot of times, regretfully, it's because they're too busy typing on a computer to look you in the eye and talk to you. One of the things that slowed me down and make me have to come home, but these days you got AI to help out a lot better. But one of the things that concerns me is that physicians are too busy being data entry people. Entering data into that person's medical record. Yeah, you want them to capture it, but by the same token, how can you be entering that data and not listening to me if you constantly sharing that screen? Or if you got your back to me, talking to me, automatically I'm going like, well, this fool can't even look at it. I mean, I say that as a physician. This fool can't even look at me. I don't trust him as I can kick it. And so I can see why patients would say that to me. If I did that, luckily I don't do it, because I have an aunt who's like my grandma. She was the grandma for me. She said, you look a man in the eye and it'll tell you a lot. Okay. They can't look you in the eye. That's a problem. That may be a problem, significant problem. Okay. Because if you can look them in the eye and they can look you in the eye, there a certain level of trust may be created. A better level of trust can be created. Because
I've heard people say, you talk about looking, Dr. Kane, I've heard people say they've gone to their primary care physician and the primary care physician never touched them.
Look, it ain't just primary. I've seen it with a specialist. I've seen the ear, nose, and throat guy. I sent the lady too. She seen him like 3 or 4 times, and she was talking about their inability to hear or their reflux or whatever it was they were talking about. And I said, okay, Dr. So-and-so said this, that, and the other, yada, yada, yada. He wrote a prescription for that. So how's it working? And I hear silence. And I look and I'm going like, so what does that mean? And they say, Dr. Kane, be honest with you, this patient been a patient for mine a good while. They were a professional. As a matter of fact, one of them was a vice president of one of the local major insurers. He was a vice president. They say, that person never even touched me. They were on the other side of the room. They act like I had the cooties or something like that. We laughed about that, but they act like I had some kind of cooties, and then want to start writing prescriptions for me. But then I look in the chart and I'm going like, whoa, whole physical exam from what that patient from head to toe, you know, and I was quick. I called that physician out, and again, it ain't about me and all that. I called him out. The president, the CEO of the hospital at that time, wondered why I didn't refer to that physician, and I just outright called him out as to what it was. One was the main thing was none of that ever occurred with the patient that I identified with, the Caucasian patient. None of the black patients, okay, had ever been touched by this individual. They sit on the other side of the room and examine them. I don't know how, but electromagnetically or whatever the heck you
Osmosis.
osmosis, they examined them by that mechanism and then wrote a full, complete physical exam. And so I called him out and I said, why? He asked me why I want to refer patients. I said, because he's a racist. He said, why do you say you're racist? I say, all my black patients, many of my black patients, they'll never touch me. But that I never heard a white patient complain of it. And the one time that I really want to get into is the time in which the person went over there, and again, they were VP of a major insurance company here. People didn't know they were VP. It was dermatology. They had some huge eczema rash. I mean, it was really bad to the point where flakes and stuff falling off their skin and so on and so on. So when they came back, they asked me, they said, why you refer to that doctor? I said, because it is a dermatologist. I didn't know a particular dermatologist. I knew of him. I heard some good things about him. Sometimes you got to remember who it is you heard about it. But I said, because that group is there, yada, yada, yada. And she said, well, let me put it this way. I was in the physician. They never touched me, never examined me. Now, you know about dermatology, you got to look at those lesions and that rash that they have. And then they said, turn around and said, not until this, a nurse APRN came in and looked her over and they flipped through the page and said, where are you working? They saw where she worked at. And she said, excuse me a second. And she had seen these people about 4 or 5 times. All of a sudden, 5 different people coming in there looking over from head to toe. I mean, it was like somebody performing CPR because they realized the screw up. Okay. And I'll be honest with you. I told her, like, don't never tell them anything about what you do. Like I do many a times when I go in the physician's office, because I want to see the validity of that physician, not because I'm a colleague. I don't deserve any more special treatment than either one of you guys when you go see your doctor. We got the same kind of doctor. They should treat me and my concern the same way they treat Tyrone and the same way they treat Miss Turner, and not because I'm a physician. I might, they can acknowledge them being a fellow physician, but I shouldn't get any special treatment. That I should get the right treatment every time. Just like you should get it, and you should get it. Well, I'm pointing at you guys individually. But that's my basic point, and that is, it is person dependent, it's personality dependent, and it can determine the outcome of how well it can determine the long-term outcome of what that patient experiences and the success of their therapy.
Yeah, this is to me, this is a very complex conversation. It's definitely not one that we ever thought about, or we didn't think when we started this conversation tonight that we were going to have all the answers. The purpose of it was really to just highlight some things. From my perspective, I'm out in the community and I hear what people say, and then I try to dispel myths that people have or either I always challenge people to go back to their physician, ask questions. The one good thing or important thing that Tyrone said at the beginning is that you should have a list of questions to ask your doctor when you go in. Because I know I've been to the doctor and I'll say, golly, I forgot I meant to ask them such and such. So when you're going to the doctor, have a set of questions so that you will ask them, because the bottom line is we do want people to have a good relationship with their physician, especially, but not limited to, their primary care physician. Because the primary care physician, one thing I've learned lately is I help one of my relatives with talk about mistrust. And so it's not just me. I shared this with Dr. Kane. I helped one of my relatives with their health care, and they changed insurances. And the new insurance card had a physician who's not even in practice anymore as
Exactly.
my relative's primary care physician. And I can't get them in for an appointment because they don't have a primary care physician. They didn't have any refills on their medications, can't get medicine filled because they don't have an assigned primary care physician. So we really need to help our older relatives, help our relatives who just are confused or who lack trust in the healthcare system, sometimes as family members. And we may not be the child of the relative, we may just be a niece or a nephew or a godson or a godmother, or I mean a goddaughter or whatever, a neighbor. Really, pay attention to what's happening with folks. Well, guess what? It's 7:32. We are beyond the hour. I would like to, as I always do, treat our guests, even our own family guests, our Pause for the Truth team, with sharing their final thoughts as we wrap up tonight's discussion. Tyrone, I'm going to start with you. What are your final thoughts regarding tonight's discussion?
Well, first of all, I want to thank all our listeners and viewers for tuning in. This is a very important conversation. This is a conversation to share. This is a conversation that you should be having with friends and family members and everything. Because what it all boils down to is something we've had on many shows, is that in when it comes to medicine and your health, you have to advocate for yourself. You have to be willing to be uncomfortable in order to get the necessary information to get you the best care. And then once you got that information, I am a firm believer of passing that information on. Don't hold on to it. Tell everyone who will listen. I was at the doctor. They should get tired of hearing you saying I was at the doctor. But this is what I learned. And I want you to have this information because it will help you as well. So when you're considering your own health care, remember to be a strong advocate for yourself. Have the desire and understanding that it's important to have communication with your physician, because the overall goal is a healthier you.
If I were at church, I would say, Amen, Pastor. Dr. Kane, what are your final thoughts? Thank you, Tyrone.
Well, it won't be pastoral, but I will say this much. I want to talk to two different sets of people and then a generality. Again, thank our listeners for allowing us into their living rooms and their cars and wherever they may be listening to us from. We really appreciate the confidence that you have in our program. With that being said, or at least to be able to listen to our program. With that being said, let me talk to my fellow physicians first, okay, which I'm not preaching at them. I am discussing, providing to them some of the concerns that I experience. And a lot of them can tell me even more about those same concerns that I'm about to say to them. And that is, please be sure to listen to your patients. We know sometimes particularly when you employ physicians, you're operating on a time budget, scheduling, and try to take in consideration how you can best serve that patient. But most of all, just treat that patient or your patients as if they were family members. And what you would want to happen to your family member given the same exact situation or a similar situation. So that's to my fellow physician. And, there's many of them out there that they do it, and there are some others that may not. But at least I want to put that out there. As far as the patients are concerned, as you said, Ms. Turner, bring in a list of questions. Now, as a physician, because I still have some level of time restraints that I got to abide by. One of the things I will do is I say, give me those questions. And I want to go down and read them myself because I can ask, what does this mean? Or I can explain it, and we still have good timing with it. And whether or not I need to do this, that, or the other to answer those questions, I can help facilitate the timing or the brevity of that encounter to where, it can stay within a certain time period so I can respect other patients' time. So, don't be, if anybody that's out there listening to me and that's Dr. Kane, I'm going to bring in some questions. Don't be surprised if I'm looking at you and you got 8 questions, 10 questions, like, give me them questions, and then I go down the line and ask them and let them know I can't answer it this time, but let's look at this, that, or the other. But at least they know there will be at some point that we can address those concerns. And I usually try to pick out the most concerning efforts. And again, I'm not the only one. I got many of my other primary care providers that are really smarter than me, okay, and that take that's a major milestone to get past being smarter than me. But that they will take that time out and they do the just in terms of the justice in terms of what those patients deserve.
Thank you, Tyrone. Thank you, Dr. Kane. And as Tyrone, and he always opens up by saying, I'd like to first thank our viewers. As we close today's conversation, I want listeners to know this. If you've ever felt unheard, dismissed, rushed, or judged in a healthcare setting, your experience is valid. Trust isn't built through pamphlets, policies, or one-time outreach efforts. It's built through listening, humility, consistency, and respect. This trust gap didn't happen overnight, and it won't be fixed overnight. But acknowledging it is the first step. In the next episode of this series, we'll talk about what happens after the appointment, when doctors prescribe a plan, but real life gets in the way. It's a common thing that people say, well, life got in the way. Until then, we encourage you to pause for the truth. You deserve care that sees you, hears you, and respects your reality. We're going to have a trust building checklist on our website, something for you to reference, something for you to think about, something for you to have a conversation with in your circle of influence, and perhaps even have ask a physician or a nurse to come in and have a conversation at your church with your ladies group, your men's group, or what have you, and have these conversations. So as a community, this is something we can work on together. And of course, don't forget to subscribe to our YouTube channel, like us on Facebook, and stay well and safe. Take care, and see you next week on Pause for the Truth.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.